Good afternoon. We are so glad to have you all with us to talk about how we can all be our best for mothers and babies. I'm KPRC2 health reporter Haley Hernandez, and I am proud to partner with March of Dimes today to bring you an informative discussion on how hypertension can affect how we all can be our best for new and expecting moms and babies. That is, as a new or expecting mom yourself, or as a support person helping a new or expecting mom. We all want to be the best for our babies. March of Dimes leads the fight for the health of all moms and babies, no matter who they are, where they live, or what they can afford. And we all agree that everyone deserves a fair and just opportunity to be as healthy as possible. And right now, that is simply not the case. There are significant disparities in birth and health outcomes across the life course based on race and ethnicity. The prevalence of hypertension is highest among non-Hispanic Black adults at 42.1%, compared with non-Hispanic white adults at 28%. Hispanic adults at 26%, and non-Hispanic Asian adults at 24.7%. Now, for women, hypertension is one of the leading causes of maternal mortality, and African American women are 3 to 4 times more likely to die from complications like this related to pregnancy compared to white women. We are thrilled to share a quick mission moment from a local family on how their lives have been impacted by March of Dimes services. I'm pleased to welcome Dr. Cassandra Wirtz and her daughter, Sophie.
Hi, I'm Cassie.
I'm Sophia.
And I had preterm labor with this one and delivered at 24 weeks. I was a second-year internal medicine resident at that point, and despite that bit of medical knowledge, missed a few signs that I had impending labor doom. Interestingly, my husband and I were in New Orleans at the time, so we made a speedy, frantic trip back to Houston down I-10. Made it straight to L&D and had phenomenal OB care. My pregnancy was perfectly fine until it wasn't, but they took great care of me, did everything that they possibly could, but things progressed, and this one entered the world just a few days later. And we made, our transition to the NICU. And again, we had excellent care in the NICU, everything that you could want in the Medical Center of Houston. But medical care, or care rather, isn't just medical. And as a physician, I can tell you, and most people know, our healthcare system is lacking in some of those finer ways. And the NICU has the March of Dimes, luckily, and they step in very early and are a clear line of support for families who are going through an incredibly trying time, and nothing that anybody ever prepares for or thinks that could happen to them. But it happens to everybody. It could happen to anybody at any time and for a number of different reasons, right? And one of the very early encounters that I had with March of Dimes was a lovely lady named Angela, and she gave me this book that I called my Bible of the NICU, and clearly 10 years later, I still have it. And I am not a keeper of things. I don't have books from college. I don't have books from medical school, but I still keep that book because it was that important to me. And, the other thing for us, obviously making our way through that journey and leaning on the March of Dimes for their support and education, then to turn around, she was born in March, and then in April was our first walk. And we've been involved with the walks ever since in some way or another. And this year was kind of especially powerful for me in terms of it being kind of a full circle year of, going way back in my family. My grandmother was involved with the March of Dimes as a volunteer in probably the 50s or so. And to think that had an impact on my daughter. And now my daughter has been involved on her own, not just with our family, but kind of took off with her own plans this year. Do you want to tell them about that, Sophie?
I have done refrigerator art. I have made books. I've made my cousins get into it. And I have forced my aunt to sell cookies.
How much money did you raise?
About $600.
Mm-hmm. Do you have any plans for next year?
I think I will keep on doing it.
Yeah, I think we will keep on doing it forever. And, to give back to an organization that has given our family so much, and that, we want to help give to families as well. We are so excited to be a part of it. Thank you.
Thank you for sharing your meaningful story, Cassandra and Sophie. We thank you for joining us today. No matter the circumstances, becoming a mom is a full-time job of both joy and stress. I would like to now welcome Dr. Diana Rakusin, who is the Assistant Professor, Department of Obstetrics, Gynecology, and Reproductive Sciences at McGovern Medical School at UT Health Houston, and Maternal Fetal Medicine Specialist at Children's Memorial Hermann Hospital. Dr. Rakusin will be sharing with us how we can all be our best for our babies by addressing heart health across our lifespan.
Hi, my name is Dr. Diana Rakusin. I am an assistant professor in the Department of Obstetrics, Gynecology, and Reproductive Sciences at McGovern Medical School at UT Health, as well as a maternal fetal medicine specialist at Children's Memorial Hermann Hospital. I'm here today to talk to you guys a little bit about what my job as a maternal fetal medicine specialist entails and things that pregnant women or women can do even before they become pregnant with their general health to optimize pregnancy outcomes, to ensure the healthiest moms and babies that we can have. So people ask me all the time what a maternal fetal medicine specialist is. And the easy answer, what I tell my children, is that I am a high-risk OB-GYN doctor and I take care of sick mommies and sick babies. In reality, my job is a little bit more nuanced. I sort of wear three hats in my job. I do prenatal care for pregnancies that are complicated by either maternal or fetal complications. I do consultations for general OB-GYNs where I look at a patient's medical history and I provide a plan of care throughout the pregnancy. And this could be a one-time thing or something that we do over the course of multiple appointments or throughout the pregnancy. And finally, I'm trained in detailed ultrasound. So I think of myself as kind of a radiologist for pregnant women, where I look at complicated ultrasounds of pregnancies. I do anatomy scans, fetal echocardiograms, and check on the status of the pregnancy through ultrasound. So those are the three things that I do on a daily basis. And all of those things together help me provide comprehensive care for today's pregnant patient. So when I talk to people who are planning a pregnancy, I always encourage the planning portion of that sentence. Planning early, being thoughtful in your decision making, and consulting with your physicians is probably the best way to ensure a healthy pregnancy, because there's so many things that go into pregnancy that we may not think about that seems obvious, but really if we don't address them early on, they can have very impactful changes on what happens in the pregnancy and in the health that comes thereafter. So what I always tell people is that pregnancy is a stress test for your general health. It sort of uncovers underlying predispositions to certain medical conditions, and anything that you had pre-pregnancy is going to be exacerbated in the pregnancy time period. So I'm going to give you a couple of examples. Let's start with something like diabetes. So you may have heard of gestational diabetes, which is diabetes that develops in pregnancy. Women that develop diabetes in pregnancy actually have a 50% increased risk for developing type 2 diabetes in their lifetime. So all this does is when people develop diabetes, it just tells me, yep, you're at increased risk for developing type 2 diabetes. And the tricks we learned in pregnancy are important for the rest of your life. Sort of conversely, people can come into pregnancy with existing type 1 or type 2 pre-gestational diabetes. Those women have different challenges in that it's very important to get that diabetes as well controlled as possible to minimize risks to babies. So babies of diabetic mothers can be at increased risk for something we call macrosomia, which means being a big baby. They can be at increased risk for going to the NICU for issues such as hypoglycemia, low blood sugar. They can have issues even with breathing at delivery. There's also a slightly increased risk of stillbirth. That's really important in women who have very poorly controlled diabetes, but that risk can be mitigated by improving and optimizing diabetic control. And so all these things add up. Additionally, they can be at risk for structural abnormalities, so heart abnormalities, spine abnormalities, and that comes from exposure of the fetus to high blood sugar in the first trimester. So it's really, really important that diabetes be as well controlled as possible when mom gets pregnant. Many times people get motivated to get these things under control, but by the time they've presented to care, we may be out of that first trimester window already. So if somebody has diabetes, they may be so focused on getting pregnant that they miss that important piece of getting that diabetes under control prior to getting pregnant to ensure that pregnancy is as healthy as possible. The other thing about diabetes and pregnancy is that people can sometimes get discouraged because their glycemic control can become more and more tricky as time goes on, because as that placenta grows, we sort of have to fight an uphill battle to keep those sugars under control. So I always warn people, just be prepared. We're going to be changing your medication as time goes on. Another example is high blood pressure. Similarly, when people get pregnant, they may not think, gosh, I had this high blood pressure. It's no big deal. I've had it for years. But again, the control you have of your medical problems coming into pregnancy reflects what's going to happen in pregnancy. So people with very poorly controlled hypertension, they're at increased risk of developing a condition called preeclampsia, which is high blood pressure caused by the pregnancy. This can lead to things like seizures and strokes and early deliveries. And we can't eliminate risk, but we can certainly mitigate it by controlling our blood pressures and knowing everything we can on the front end, so we go into pregnancy in the best condition we possibly can, with an open and being prepared for any sort of challenges that might arise. Sort of the last condition I want to talk about briefly is lupus, because I think it's a really great example. Lupus or any other sort of autoimmune condition where they can have adverse side effects in pregnancy. But women that have great control prior to pregnancy have excellent pregnancy outcomes. So all these kind of scary things you might read about, really, those risks are reduced when people don't have flares constantly. So I would, having a patient who says, gosh, this has been in remission for a long time. I haven't had a flare in a year. That's a very different prognosis than somebody who has a flare every month or every 3 months. So it's really, really important to know about these things, talk about these things, and optimize medications prior to even getting pregnant. I would encourage patients to seek out the care of their obstetrician gynecologist and possibly even have a preconception consultation with their maternal fetal medicine specialist. We do these all the time, where we can look at your history and make a plan for whether this is a good time to get pregnant, and if it's not, what we can optimize prior to moving forward with pregnancy planning. Additionally, talking to other physicians that may be part of your care team, endocrinologists, a rheumatologist, cardiologist, whoever may be involved in taking care of you, and letting them know that you're planning a pregnancy, so we can make sure that the medications you're taking are safe for pregnancy and that your condition is well controlled. Even things like IVF pregnancies, we may not think about that as something that we should talk about prior to getting pregnant, but we absolutely should, because even IVF pregnancies need increased surveillance in pregnancy. We definitely want to make sure that our pregnancies that result from in vitro fertilization, that we do what we call an echocardiogram on the baby, that we make sure that baby doesn't have a heart defect, because it turns out babies born of IVF pregnancies have a slightly increased risk of having a cardiac defect. So we want to make sure that we are very careful and we watch carefully in pregnancy, and we learn everything we can about that baby's heart to make sure that there's nothing coming up that we need to know about. Similarly, IVF pregnancies need increased surveillance to make sure that baby's growing well, and at the end of the pregnancy to make sure that our placenta continues to work well and that we're doing great as we move towards delivery in the third trimester. Sometimes, going back to even the healthiest of pregnancies, there's things that we can still do there to optimize pregnancy as before pregnancy. So we all know that we take prenatal vitamins and that we should take those when we get pregnant. It might be surprising to learn that actually the best time to take prenatal vitamins is to start before you get pregnant. one of the things that we want supplemented in our prenatal vitamins is folic acid. And one of the reasons we want folic acid is to reduce the risk of a baby being born with a neural tube defect. But the baby's neural tube forms by day 28 of life. So that's super early in the pregnancy. It's earlier than most people present to care. So actually, if you're a woman of reproductive age, we really want you taking those prenatal vitamins long before you get pregnant to ensure that you have adequate levels of folic acid before you ever contemplate pregnancy. So I would encourage any women out there of reproductive age to be on a multivitamin for women or a prenatal vitamin before they're pregnant. It's really important that we sort of optimize these medical conditions prior to pregnancy so that when we enter pregnancy, even if we have medical problems that are ongoing, that we can manage them and optimize the pregnancy to ensure the healthiest outcome for mom and baby. I really encourage you to reach out to your OB-GYN physician and to a maternal fetal medicine subspecialist to ensure that you would have the healthiest pregnancy possible. Thank you.
Thank you, Dr. Rakusin. Of course, we all want to be the best for our babies, and I appreciate all of you joining us today and paying attention to your own health so that we can provide that much needed support to new and expecting mothers. I hope that this information will provide some insight into your own wellness journey. Of course, reach out to your primary care physician to discuss any of the signs or symptoms that we've discussed today. Now, I would like to welcome Dr. Nicole Plenty with Mednax. Dr. Plenty is an obstetrician who has gone through special training to treat expecting mothers who are at a higher risk for poor birth outcomes, referred to as a maternal fetal medicine specialist. Dr. Plenty, welcome, and we look forward to hearing from you about how expecting mothers can take the best care of themselves along with their medical providers during pregnancy.
Thanks so much for the introduction, and thanks for the opportunity to share with each and every one of you. And so today we're going to talk about preeclampsia and how that affects pregnancies and maternal outcomes. I'm Nicole Plenty. As she said before, I practice high-risk OBGYN, which basically means I take care of women that have complications in pregnancy. So when we talk about what preeclampsia is, people are like, what's that big word? Well, it basically means that you have high blood pressure and protein in your urine that's diagnosed after the 20th week of pregnancy. And it's thought to be caused by all these hormones that are secreted from the placenta or the afterbirth that cause constriction of vessels at the level of the placenta. So if you look at this image, in the normal pregnancy, we have normal flow. The vessels of the placenta are more dilated. With preeclampsia, because you have all these hormones that are circulating, those vessels are now more constricted. So it acts as if there's high blood pressure, but it's just basically at the level of the placenta, which then can present systemically as high blood pressure later on. Preeclampsia happens really early. So we do things really early in pregnancy to try to prevent preeclampsia. But because it's caused by so many different hormones, it's difficult to 100% reduce or prevent this from happening in pregnancy. It occurs in about 3 to 8% of all pregnancies. For me, it's relatively common because I treat people with preeclampsia all the time. But for a general OBGYN, they may only see it, a couple of times a month, whereas I see it almost every day. It does cause significant preterm deliveries and poor neonatal outcomes because the cure for preeclampsia, or the definitive cure, is to deliver and get rid of the placenta. We can't get rid of the placenta or deliver the placenta without also delivering the baby. So when we talk about preeclampsia versus high blood pressure, a lot of people get very confused. So if you have high blood pressure or hypertension, that means you have elevated blood pressure, which is 140, the top number, which is the systolic number, or 90, the diastolic number, before the 20th week. If you have any history of high blood pressure outside of pregnancy, that is also diagnostic of hypertension or what's known as high blood pressure. That means you have some underlying vascular damage that could be long-standing because, like I said before, when you have high blood pressure, that's caused by constriction, that causes constriction of those vessels. And so if you have that long-term, that can cause damage to other organs. And although hypertension is not preeclampsia, if you have high blood pressure, you do have an increased risk of developing preeclampsia as well. Now let's talk about preeclampsia. So we already said it was high blood pressure that's caused by all of these hormones that are secreted from the placenta. So you have the same diagnostic criteria for hypertension, meaning the blood pressure being 140 over 90. It has to be documented 4 hours apart plus protein in your urine. So preeclampsia is just high blood pressure and protein in your urine. That happens after the 20th week, as we said before. Proteinuria or protein in your urine is a sign of vascular damage. So that's how we measure the vascular damage. You can have preeclampsia with or without severe features. And when we say severe features, we mean really, really bad preeclampsia. And that is looked at as a persistent headache that doesn't go away with Tylenol. It could be pain over your liver, the right upper quadrant pain, or you can have double vision or change in your vision. Those are symptoms of preeclampsia. And if you have symptoms, even if your blood pressures aren't severe range, then that means that you have severe preeclampsia. When we say severe range blood pressures, we mean anything that's over 160 systolic or 110 diastolic. So if you have either or, that would be a severe blood pressure. So severe blood pressure alone or those symptoms mean that you have really bad or severe preeclampsia. And you can also have associated damage to other organs like the liver or the kidney, or you can have low platelets that put your risk for bleeding. And so, as I said before, symptoms of preeclampsia include headache, blurry vision or change in your vision, and then pain over your liver, which is on the right upper side of your abdomen. So who's at risk for preeclampsia? So if we look at the data, and this is data that we use for Texas AIM Hypertension Collaborative that's obtained from the CDC. So when we look at the data over time, we see that the dark purple have a really high risk of preeclampsia. And we can see that the dark purple are African-American women. They have a much higher risk of preeclampsia than any other ethnicity. Following that, we have American Indian and Alaska Native American. Hispanics also previously had a higher risk of deaths related to preeclampsia, but over the past decade and a half, that has significantly decreased, but their incidence of preeclampsia itself, not displayed here, is higher than our Caucasian counterparts, but less than African Americans. So African American women have basically 3 to 4 times the risk of preeclampsia as Caucasian women. So the example and case in point, this is my why. So this is my cousin Kenyatta. She passed away from complications of preeclampsia. She developed eclampsia, which is when you have high blood pressure plus protein plus a seizure, an eclamptic seizure in pregnancy. She had aspiration pneumonia and she passed away. She had no risk factors besides being African American for preeclampsia. She was delivered urgently at 29 weeks. She went to 3 different health systems because she was helicoptered to different systems for higher level of care twice. And she still passed away at the age of 23. And it's cases like this that make me very passionate about preventing preeclampsia and making sure that you understand the signs and what to look for. She was in a very small town and she was sent home because her headache was thought to be something very, very simple. And it wasn't until 2 days later that she developed a seizure, and then a month later that she passed away. And so being very proactive and making sure you understand your symptoms and you're communicating with your OBGYN specifically to make sure they understand what's going on can prevent things like this from happening. So who else is at risk? So we already talked about being African American or Hispanic puts you at risk for preeclampsia. But if you're over age 35, you are higher risk for preeclampsia, or under the age of 19, you're also at risk. If you have a history of high blood pressure, if you have pre-existing diabetes, so you have type 2 diabetes or type 1, you're at increased risk. If you have an autoimmune disorder like lupus or thyroid disease, then you have an increased risk. Anything basically that can affect the underlying vascular process. So since people with autoimmune diseases, that's a vascular process, that's why you have a heightened risk of preeclampsia. And then if you have a previous history of preeclampsia, then you have a high risk of preeclampsia with all of your future pregnancies. So when we treat preeclampsia, after we diagnose it, there's two train of thoughts. Either one, we can conservatively manage you, or you may need to be delivered. People that don't have severe features. So remember, I talked about symptoms of preeclampsia being headache, blurry vision, and pain over your liver. So if you're asymptomatic, if your blood pressures are less than 160 systolic or 110 diastolic, and your labs are normal, then technically you don't have severe features. You have preeclampsia without severe features, then we would consider conservatively managing you if you are less than 37 weeks. If you're over 37 weeks, we would go straight to delivery. If you have any of those severe features that I just mentioned, then you would need to be delivered, and that's regardless of the gestational age if it involves symptoms. If your blood pressures can be controlled and that's the only thing that's abnormal and you're less than 34 weeks, then your OBGYN would work with someone like me, who's a maternal fetal medicine specialist, to try to get you further into the pregnancy and deliver you at 34 weeks. So it really depends on the gestational age, the symptoms, the labs, and if we can control your blood pressures or not. Sometimes we give you antihypertensive medications like labetalol or Procardia to try to control your blood pressures if your labs are normal and your symptoms are not persistent, to try to get you further along. But if we can't manage your blood pressures despite giving you antihypertensive medications, then we would deliver you. With or without the delivery, you would need magnesium for seizure prevention. That helps prevent, like what my cousin had, which is an eclamptic seizure. So when we say pre, that means before, and then eclampsia is the seizure. So we would give you magnesium. So once you're delivered, if you have preeclampsia, you still need magnesium because you can get preeclampsia in the postpartum period too. And that's really important to know, that even if you had an uneventful pregnancy, if you develop a headache 7 days after or any time before the 6 weeks postpartum period, you need to let your OBGYN know. So if you take Tylenol, it doesn't go away, you need to call your OBGYN or go to the nearest hospital so they can evaluate your blood pressure and check labs to make sure you don't have preeclampsia, because you can get it after you deliver, even if you don't have a history in the pregnancy of preeclampsia. Even if you didn't have blood pressure issues in the pregnancy, it's still very important for you to know the signs and symptoms so you don't develop it afterward and it become undiagnosed or unnoticed until you develop an eclamptic seizure. So how can we prevent it? So now we know that aspirin blocks some of the hormones secreted from the placenta. And we used to do one baby aspirin, but now we know the newest data says we need at least 100 milligrams a day. And so we recommend 2 baby aspirin started before the 16th week. And usually we start that somewhere between 12 and 16 weeks. Taking that aspirin that early reduces your risk of preeclampsia by about 15 to 20%. So we want to make sure that we have the aspirin on board. You would take those 2 baby aspirin every single day until the 37th week. And then they discontinue it because you're full term already. Now, if you have a history of bleeding disorders or certain platelet aggregation or platelet issues, then you definitely need to talk to your OBGYN before you just start the aspirin, okay? And there's been no benefit shown with starting aspirin over the 24th week. So it's pertinent that you started early to help reduce your risk of preeclampsia. The other thing I would encourage you to do is make sure your medical issues are controlled before the pregnancy. So people that have uncontrolled diabetes and uncontrolled high blood pressure have a much higher risk of developing preeclampsia than those that have well-controlled high blood pressure and well-controlled diabetes. So the best thing you can do to reduce your risk during the pregnancy is to make sure that your comorbidities are well controlled before the pregnancy. Same thing with autoimmune disorders. You want to make sure that you're flare free if you have lupus before the year before you get pregnant, because that will reduce your complication rate during the pregnancy. If you have hypothyroidism, you want to make sure your thyroid hormone is controlled before the pregnancy so that it's easier to control and adjust you during the pregnancy. And that also will reduce your risk of having preeclampsia as well. And then, of course, monitor your symptoms. So although this doesn't prevent preeclampsia, monitoring your symptoms helps us diagnose preeclampsia early and allows us to be aggressive in trying to conservatively manage you if you get preeclampsia earlier than 34 weeks. So just make sure you're monitoring your own symptoms, advocate for yourself, and make sure you're persistent. So if you know you have a headache and it's not going away and you call and they say, oh, just lay down and take a nap or take Tylenol or hydrate, keep calling, call the next day and say, there's something wrong, because you don't want to be undiagnosed with preeclampsia or develop some other complications such as eclampsia or even a heart attack or a stroke because of blood pressure issues, because you're not persistent. And then lastly, you want to advocate for yourself, but you're also advocating for your baby. Preeclampsia puts the baby at risk for being smaller because, like I said before, those vessels are constricted at the level of the placenta. So you want to make sure that you're advocating for yourself and your baby so that your baby can be monitored so we can know exactly what's going on with the placenta. So that's all I have for you. If anybody has any questions, you can email me at pregnancypearls@gmail.com. Thanks so much for listening.
A lot of this work to stay heart healthy begins at home with what we are hearing on a daily basis. Here to talk about how we can be our best for our babies by keeping a healthy diet from birth through adulthood is Stacey Mattinson, registered and licensed dietitian.
Thank you so much for that introduction, and thank you for having me today, March of Dimes. I am so excited to talk about prenatal nutrition and nutrition for moms and young families. I am here with you in the depths. I am just a few weeks away from having my third child, so anything that I'm saying is from personal experience aside from the science behind it. Now, as you may or may not know, prenatal nutrition is really important. Really, that nutrition before you're even trying to conceive. So a healthy pregnancy truly starts before pregnancy comes along. Pre-pregnancy is important because healthy prenatal nutrition plays a role in your fertility, and it also plays a role in the development of your baby and the habits that you'll set up for your whole family to come. Now, before you begin trying to get pregnant, you do want to start, of course, with a prenatal supplement. Ideally, you start that at least a month before you start trying, but it might be 2 to 3 months before you start trying. And the reason you want to start before you start trying is because there's a lot of development that happens, this embryonic development in the first 8 weeks of life. And if you know, or maybe you don't, you really aren't going to know that you're pregnant until you're probably about 5 or 6 weeks along. So making sure that you have that prenatal nutrition in place before you get pregnant is going to be very important to make sure that that fetus starts developing properly when the time comes. Now, the other piece of this is that if you've been pregnant before, you may know that your cravings and what sounds good to you and what you can actually tolerate between the nausea and heartburn and just generally feeling like you're not up for spending a lot of time in the kitchen, you want to make sure that all of your nutrition stores are really in place before that baby starts trying to get nutrients from you. So making sure that you have things moving along in a good trajectory nutrition wise before you get pregnant and might be on the couch or may not be making those amazing meals that you were before can really set baby up for good development. So let's dive into to my plate. Sorry. All right. So now we're going to dive into my plate, which is, if you remember, maybe a long time ago, we used to have the food guide pyramid, and now we've moved on to a plate, which is really a great visual for how we actually eat and how we can help best set up our plates for nutritional success. So I'm going to share my screen here. Okay. So some of you may or may not have seen this visual before, but this is a really great way to start thinking about how we can plan our plate. Now, and we are really focusing here on reducing hypertension and making sure that we have a healthy pregnancy overall. So I'm going to be weaving in some of those heart healthy principles as we go through this. So this works for prenatal nutrition before you're getting pregnant. Preconception nutrition. This is also useful during pregnancy. This is also useful postpartum. So wherever you are on your conception scale, this is something that you can really implement. And I'll point out some key points that are going to be important, particularly for pregnancy. But this is a great basic guide, no matter where you are, and for your family as a whole. So when we think about how we plan our plates each day, we want to think about starting with leading with some high fiber foods. So first, we want to think about making half of our plates fruits and vegetables. Now, in this case, this is fruits and vegetables both on the plate. When I'm working with clients, I like to say, if you can have at least a fruit or vegetable at breakfast and then both at lunch and dinner, that will give you at least your 5 servings of fruits and vegetables a day. So that's minimum recommendations for fruits and vegetables daily, is 5 servings a day. Some recommendations actually go up to 8 to 10 servings a day. So if you can have one or the other at breakfast and then both at lunch and dinner, you're going to be covered. So half of our plate, fruits and vegetables. I also like to emphasize here on the vegetables, your non-starchy vegetables, which non-starchy vegetables are pretty much any vegetable other than potatoes, peas, corn, which I kind of work into that grains and starches category up there on that upper right. So focusing on a lot of color here. So leading with our fruits and vegetables are going to be a great source of vitamins. Minerals are going to be important for you, important for baby. And they're going to be a really great source of fiber. Fiber is important for overall heart health. It helps rid the body of some of that LDL or bad cholesterol, helps bind it and helps remove it from the body. So it also is very filling. Things that help trigger those satiety signals that are going to make you feel full and satisfied throughout the day are going to be high fiber foods and high protein foods. And really fruits, vegetables, and your high fiber starches and grains, meaning we're looking for whole grain options here primarily, or your starchy vegetables, which are going to have fiber in them as well. These are all things that are going to help trigger those feelings of fullness, help you feel satisfied, and also going to be helpful for you and for baby. They also are really particularly helpful for your gut. They help make, you have a few different types of fibers, two, soluble and insoluble. They help provide bulkiness in your stool. They also help with motility, moving things through. So also make sure that you have a really healthy gut and gives nutrients for those healthy gut bacteria to feed off of. Last is going to be our protein, and we're really looking for lean protein sources here. So examples of your lean proteins, these can be your animal sources of protein like lean beef, chicken, fish. They could also be non-animal sources of protein like soy, tempeh, beans are also going to be in that category. So you have some foods that kind of cross over between a starch or a grain and a protein. You can kind of use them in your plate interchangeably. Last here is going to be dairy, and oftentimes when I talk about dairy, I talk about it as a protein source that you can include at your meals. But when we are talking about prenatal nutrition and nutrition for pregnant women, we actually really need that extra calcium, which I'm going to talk about briefly in just a minute. So we'll dive in there, but we are going to want to include three servings of dairy daily, ideally during pregnancy or using a supplement. The reason is because during pregnancy, if you don't have adequate calcium stores, baby will actually begin to take it from mom. So you have to think that baby isn't just necessarily coming up with all these nutrients on their own. They're getting them from you. You are their source of nutrition, especially while you are pregnant. In fact, it's more important while you're pregnant than just nursing, because of how directly your baby receives those nutrients from mom. So, regardless of where you are trying to get pregnant or afterwards, this is a fantastic visual for how you can set up your plate for success. The difference is just going to be calories, meaning maybe you're taking in more calories during pregnancy and lactation. So first trimester, really no difference. Second and third trimester, you are increasing those calories, which again, we'll talk about briefly in just a moment. The last thing that I want to touch on in terms of heart health and this My Plate guide, aside from making sure that we have adequate fiber in our diet, which again, you're going to receive from your fruits, your vegetables, your grains, those are going to be your fiber sources. Again, we're looking for, if you're purchasing bread, you want to look for 100% whole grain. If it doesn't say 100% and it just says wheat bread, it's not going to be the same amount of fiber that you're going to find in 100% whole grain products. So other whole grains like brown rice, there are so many different options now. Farro, there are just a number of things other than just bread and rice. You can also choose whole grain pastas. I know when I'm making food at home, I'm always looking for, say I'm doing a pita bread, or say I'm making a curry, I'm always looking for a whole wheat naan or a whole wheat pita to go on the side, just to make sure I'm having as much fiber as possible. And especially if you have young toddlers, we want to, again, expose them to as much fiber as possible. We do get a lot of food jags with young kids, and they kind of get on these like chicken nugget strikes. So as many times as we can offer colorful foods, think of eating the rainbow. Different foods have different color foods have offer different nutrient profiles. So, your leafy green vegetables are going to be high in vitamin K, and your oranges are going to be high in beta carotene. So we want to think about having a lot of variety. So fiber, important for heart health, and also limiting sodium is important for heart health. Where we find sodium or salt is going to be your table salt, what you shake on, anything that comes pre-prepared or pre-packaged. When you're buying canned goods are totally okay. I'm on board. If you want to buy fresh, frozen, canned, all good with me. Just look for no added salt or low sodium. If you already have canned goods in your pantry that have sodium in them, just rinse them off before using them. That'll remove another 50% of the sodium, and that's helpful. Also, dining out is another big source of sodium in the diet. So this is something we want to help control. Last point for heart health is going to be limiting your solid fats. Solid fats like butter, coconut oil, palm kernel oil, and lard. And I know you might be thinking, well, I've heard coconut oil is like the beacon of health, but really it is a saturated fat, and we really don't have the research to show that that coconut oil is going to be significantly more healthful than your other saturated fats. So saturated fats are solid at room temperature, and they can kind of have a similar effect in your blood vessels, right? Think of like trying to get that off of a dish or making go down a drain, it clogs. So we want to use true oils as much as possible. Olive oil, avocado oil, canola oil, vegetable oils. Those are going to be your better heart healthy options. All right, so next we'll dive into increased nutrient needs during pregnancy. Again, I mentioned already making sure that you have a prenatal supplement before starting to get pregnant. If you got pregnant and weren't on one already, start on one as soon as possible. The biggest point of this is really for that folic acid and that folate. So this is a nutrient that helps reduce the risk of neural tube defects. So if you've heard of like spina bifida, this can really help reduce the risk of that happening in baby. This development happens like that first 8 weeks of life. So making sure that you have adequate stores before is important. Making sure you have adequate calories is going to be a big key. I know that a lot of us feel really nauseous at the beginning, but again, that's why pre-pregnancy nutrition is so important. You really don't need any added calories your first trimester, but second and third trimester, you do have increased calorie needs. You don't really need to necessarily count all of your calories, but if you can just think of first trimester, I'm going to eat as normal as possible. Second trimester, you have an increase of about 340 calories that need to increase. And third trimester, 450. You, again, don't need to be counting your calories, but if you feel hungrier than normal, you just need to respond to that. I always like to think of listening to your hungerful signals, no matter which stage of pregnancy you're in. Iron is going to be your most common nutritional deficiency in pregnancy. Most people, there is iron in a prenatal supplement. Again, this is why you're taking one. Most people aren't going to have to take an additional iron supplement, but your doctor would tell you if you did. They do check your hemoglobin throughout pregnancy, and if you do need another source of iron, then they will give that to you. Food sources of iron are going to be like your lean red meats, particularly like beef is a great source, fortified cereals, some leafy green vegetables, beans. Lastly, calcium that we talked about, increased nutrient needs, 1,300 milligrams per day, 3 servings daily of low-fat dairy products or calcium fortified soy milk. And that would always be my recommendation. If you are someone who avoids dairy, I would recommend soy before recommending like an almond milk. Soy milk is going to just have a higher nutritional value. Cow's milk is the most nutrient dense option, but next would be your soy. All right. Okay. So this is the fast and furious version of prenatal, preconception, prenatal, and postpartum nutrition. And now we're diving right into first foods for baby. Again, if you have any other questions, I would always recommend reaching out to a registered dietitian nutritionist or searching for one on social media or whatnot, so you have a good qualified credentialed person to help you through this journey, because it is a big, we'll call it a year between preconception, pregnancy, and then postpartum at least. So first foods for baby, we're going to start solids. World Health Organization recommends 6 months. Your pediatrician might recommend earlier. The recommendations used to be a little bit earlier, like 4-ish months. I've had pediatricians recommend my child start at 4 months when they showed interest, or if they were a little bit lower weight. So you will work with your pediatrician hand in hand, but when they're developmentally ready to start solids, they're going to show interest. They're going to be able to sit up in a high chair on their own. You're not going to be holding them up. And they will start reaching for foods. These are going to be signs that they're ready to start on solids. Again, if you have questions, please speak with your pediatrician. But some first foods that I love to start with, fruits and vegetables. I'm looking for soft skinned fruits or skinless or really soft vegetables. Again, I'm usually serving what I'm serving my family. You don't have to think about like it being so plain. I know we've talked about in the past, no spices, or make sure that they're really bland foods. They actually can have spice. And if that's what you eat as a family, then you actually do want to expose them to that at this point in time, because it's going to help them learn those food preferences, that this is what we eat as a family. But let's say I'm thinking of, breakfast, lunch, dinner, either way, I offer fruit at every meal. But so easy fruits like raspberries are really easy, especially if they're on that kind of younger side of things. I'm usually going to mash it with a fork. I call it like the hashtag mash. I kind of mash down with my fork. So if you are really hard on the baby-led weaning, then you don't modify texture at all. In my opinion, I do kind of a modified baby-led weaning, which is I'm still using the normal table foods that we eat as a family, but I do modify texture according to how my baby is responding. So if we're showing gagging can be normal, but if there's some coughing and gagging can be normal, but choking is not normal. They should not be choking on anything that you're giving them. So I like to use soft skinned fruits. So let's say some of my first foods are going to be mashed raspberries, mashed strawberries are really nice. If you think of something like a blueberry, it has a harder skin on it. I'm not going to serve something like that as a first food. Skinless or soft vegetables like steamed broccoli is a really nice one. Or if I do like a sauteed zucchini, I'll kind of remove that exterior skin and mash the little inner part of the zucchini a little bit. That's a good first food. Lean proteins to offer. Ground beef is actually one of my first foods that I offer, especially once they're able to kind of tolerate that that kind of chunky texture. Again, I have it pretty finely diced, and you can mash it with a fork as well. But mom's breast milk, especially if you are nursing, after 6 months, baby needs to have some sort of external source of iron. There's not much breast milk doesn't transfer much iron to baby. So this is a really great source of iron. 77% of breastfed babies don't receive adequate iron. And 54% have inadequate zinc intake. So ground beef is a great source of both of those. Salmon and other fishes are, salmon particularly is a great source of omega-3 fats. But fish in general is a really nice soft protein to offer to babies. And another protein that I love to offer is yogurt. It doesn't have to be Greek yogurt. In fact, your regular yogurt, and I do a plain yogurt for babies, you don't really need to have the flavored or sweetened kind for them. Regular yogurt actually is a little bit more nutrient rich for babies. It's higher in some nutrients than Greek yogurt. Particularly, it's higher in calcium and potassium. Although if what you have at home is Greek yogurt, that's totally fine. But I'm just saying it doesn't need to be. Mashed avocado is also one of my very first foods that I love to offer baby. It's a nice texture. You can modify it. It can be chunkier, it can be smoother, and it's something that most kids really enjoy. Again, offering the same foods that you enjoy as a family, modify the texture as appropriate for your child. Notice and never leave a baby unattended when they're starting on solids. It's very important. I know that you might be needing to whirl and twirl in the kitchen, but you really need to make sure that you're watching them when they're first starting solids, that there's no choking going on and they're able to tolerate everything appropriately. All right, so that wraps up our introduction to My Plate, which is a really great rubric for how you can plan your plate for success and overall healthy nutrition. We talked about incorporating heart healthy principles, reducing risk for hypertension by limiting our sodium, having high fiber, making sure that we're reducing solid fats in the diet, and then healthy first foods for baby. Thank you so much for having me. If you have any questions, please always reach out to a registered dietitian nutritionist. You can find me personally on my blog or on social, and I'm always happy to answer questions as well. Thank you again.
Thank you to all of our wonderful presenters today. We appreciate them taking their time to share their expertise on how we can all strive to be the best for our babies. Now, whether you are a new or expecting mom or someone helping to support one of these mothers, it is important for us to all pay attention to our own heart health. March of Dimes would like to recognize our partners who made this program possible today. March of Dimes leads the fight for the health of all mothers and babies, and we encourage you to use the many resources available on marchofdimes.org and all March of Dimes social media platforms. We hope that this discussion today will empower you to be the best for our babies. I'm KPRC2 health reporter Haley Hernandez. Thank you.